Okay, everyone. Again, welcome to our panel discussion. Thank you so much for being here, for working with us, even with our technical difficulties. So my name is Erica Dorsey, and I represent Public Health Advocates as the program Reach Program Manager. I'm also the co-founder of Flourishing Families Incorporated, and we also have Tamisha Valverde here as well, who is the co-founder. But she's not able to. We were not able to hear her, so I apologize. Hopefully she'll be able to. I have you down as a panelist, so hopefully you'll be able to speak soon. So we're really glad you're here today to participate in this very important discussion. And so the CDC estimates that around 830 women will die yearly from childbirth complications in the US. And over about 70% of those estimated women will be African American women. So, and we are a population that makes up less than 14% of the population in our country. So that's a huge issue. So, and for years we've known that maternal mortality is the primary indicator of the quality of care for a nation, and access to quality health care directly impacts maternal health outcomes. And even when women have access, how are they being treated? And that's a really important issue. And so the Black Moms are founded to improve maternal health outcomes, among other objectives, and established this week to bring awareness to the health inequities facing Black women. So on this third year of recognition, oh, do you mind? Thank you, sorry. Black Mamas Matter Alliance theme is centering Black mamas and their right to live and thrive. So as we are working to center the voices of Black mothers this week, I just want us to take a moment just to pause and reflect on the Black women whose voices we've lost and who have been silenced due to poor maternal care in this country. And I just want us to think for a moment about their lives, that the lives that were lost, they mattered, their voices mattered. So if you'll join me in one moment of silence. Thank you. Thank you for centering the voices of Black mothers in heart and in mind. And next, we have with us a brief review of local data from Public Health Advocates' very own Dr. Flo Kofer. Dr. Flo, are you still there?
I am.
Okay, wonderful. And followed by Dr. Flo will be an opportunity to answer any of your questions. So we do have the chat box over here. And if you're able to, you can go ahead and ask a question while she's doing her presentation, and we'll have a few minutes for her to answer your questions. So I'm going to go ahead and share my screen. And you all let me know that you can see it. Can you see my screen? Good. All right. So, and first I'll actually, so Dr. Flo Griffin Kofer is an epidemiologist who serves as the Senior Director of Policy for Public Health Advocates. She oversees the state policy efforts and the All Children Thrive California Local Trauma Policy Initiative. Professional interest is addressing emerging and persistent public health challenges through research and policy. Her work primarily focuses on metabolic disease prevention, restorative justice, and adverse childhood experiences. She previously served as the Director of State Policy and Research. Prior to joining Public Health Advocates, she led the Preconception Health initiative for the California Department of Public Health. Flojan received bachelor's degrees in chemistry and women's studies from Spelman College. Her public health training was at the University of Michigan School of Public Health, where she earned a master's in public health and doctorate in epidemiology. She is an alumna of California Epidemiologic Investigation Service and the Nehemiah Emerging Leaders Program. Flojan is deeply committed to engagement and capacities on those local boards, committees, and commissions, including the Active Transportation Commission, Mayor's Commission on Climate Change, Sheriff's Outreach Community Advisory Board, Board of Directors for Girl Scouts, part of Central California, and chairing the new City of Sacramento's Measure U Community Oversight Commission. For her professional contributions and community participation, she was awarded the Young Professional of the Year Award by the Sacramento Urban League, the Exceptional Women of Color Award by the Sacramento Cultural Hub, and the 40 Under 40 Award by the Sacramento Business Journal. That's a bad woman. So without further ado.
Thank you so much, Erica. I really appreciate that. And that was a very warm welcome. And despite having some tech challenges as we're all adjusting to our our current COVID and post-COVID world, I'm really excited to be with you this morning. And so part of what I'm going to be talking to you about this morning is examining Black maternal health in San Joaquin County. And I think it's important before we begin to really dive into, we throw a lot of terms around. We say health inequities, and when we're talking about, social determinants of health. And I never like to assume that everybody is coming from the exact same place when we're talking about these things. So I like to throw out definitions so that when I'm using these words, it's very clear what I mean. And so we're going to move to the next slide. I'm assuming you all are able to see the slides in the webinar. So part of what I think is really important for us to understand is that when we're talking about health inequities, we're not talking about disparities. We sometimes use those words interchangeably, and disparities are just differences, right? They are things that we see differently between two groups. But that may be necessary, right? There's not a disparity in cancer if we compare people over 65 to people under 20, right? Cancer is also a function of aging, and so that's why we're seeing those differences. So when we're talking about health inequities, we're talking about systematic and unjust differences in health and illness. And so, yes, there are disparities that come from health inequities, but they're not quite the same thing. Not all disparities result from inequities. And so the real distinction here is that they're based on membership in an oppressed group with historical and often ongoing restricted access to resources. So that means that we have made decisions in policy and practice and systems that have harmed certain groups of people, and then their health is impacted as a consequence. And so these are not natural. And so in the image on the side, I think it's really important just to kind of highlight some of Dr. Eiten's work. He is with the California Endowment and is really thinking about what are these power narratives that we're seeing in communities and how do they result in the disparities that we see. They are rooted in health inequities. And so if we only talk about disparities, we're often missing out on some key points around what it means to actually have systematic and unjust practices and policies in place. So moving to the next slide, part of what I think in order to frame this conversation is important for us to understand is that there is an intrinsically linked relationship between mothers and infants, right? So we can't talk about Black maternal health without also having a conversation about Black infant health. Hello? The challenge, however, hello? You still hear me?
Thanks, Ganesha. Yeah.
Yep, you can hear me. Sorry to interrupt. Muting now.
Am I good?
You're good.
Okay. So part of the challenge in having conversations around, Black maternal health is that it often defaults into Black infant health. And certainly what is good for Black infants is often good for Black mothers, but sometimes we're also ignoring, as things get better for Black infants, that doesn't always mean they get better for Black mothers. And so we need to be really clear about recognizing the relationship and recognizing the obvious importance of prioritizing Black infant health without also recognizing that Black infant health is not Black maternal health. And so therefore, it means that sometimes we're overlooking some places where we really need to work, and that is really clear when it comes to some of the things that are happening in Black women's lives. So if we look at how racism and sexism intersect for Black women's health, I want to call out a concept called misogynoir. And it is the dislike of, contempt for, or ingrained prejudice against Black women in particular. It is a portmanteau of noir, which is which is Black in French, and misogyny, which means the dislike and contempt for women. And it was coined by Dr. Moyer Bailey, who is actually a Spelman grad as well, and really kind of gave language to a concept that I think many of us have as a lived experience, which is that there is something about being a Black woman that intersects both the racism and the sexism in a particularly damaging way. And so when we think about how some of this plays out structurally in the lives of Black women, this means that, you know, we have greater caregiving responsibilities. And part of this comes from some of the other structural things that are happening in our family structures in terms of not having support, us also having a shorter life expectancy, right? That is having an impact on who's around to provide caregiving. Also the criminal justice system in terms of the impact that has on partners and on employment. And so we have to recognize all of those things kind of come together to shape and structure the lives of Black women. We are often in lower paying jobs, and that again is the combination of racism and sexism and classism. And so really understand that 72.5% of Black women who gave birth in San Joaquin County were in the lowest income category, which is 0 to 100% of the federal poverty level. And this, so having 72.5% of Black women in this category is 3 times higher than their white counterparts. In addition, during women's pregnancies, 23.1% of them lost their job or their partner lost their job just during the 8 or 9 months of that pregnancy. And that's 35% higher than what's experienced by white counterparts in San Joaquin County. And additionally, 25% had their hours cut back or their partner had their hours cut back. And that's, again, 22% higher. Now, obviously, the data I'm talking about now were collected before COVID-19 and before we had over 900,000 people signing up for unemployment each week. And so we recognize that often the jobs, these lower paying jobs, are the ones that have had layoffs or are currently not functional or not deemed essential. And so what impact does that have on the lives of the women who are pregnant right now? And some of those who, you know, we've been sheltering in place may become pregnant during the course of this shelter in place. And then there's also, and that also plays into the, you know, just overall less accumulated and inherited wealth that comes along with having lower paying jobs and not accumulating wealth during life. And a lot of wealth is passed on generationally. And so that's not always as possible in Black families. And even during the Great Recession, over 10 years ago, Black families lost more wealth than others because they were more likely to have their wealth tied up in housing. So that's an important distinguish as well. We're also, along with that, and all these things kind of tie together, overburdened by housing. And so, you know, what that means is that we spend more than 50% of our income to provide shelter for ourselves. And the recommendation is not to spend more than 30%. And so when you're spending more than 50%, that means that that's the very first thing that becomes unstable if you lose a job or if you become sick or something interacts with your ability to be able to maintain that income. And so when we think about what this means, we know that 60% of Black women in San Joaquin County who gave birth lived in high poverty neighborhoods, and that's twice as high for their white counterparts. And when we think about housing, we understand that the data on housing, on homelessness is way too unstable to present with confidence, but the pattern of homelessness and housing insecurity really mirrors some of the validated estimates that have been found everywhere. But what we do know is that 14% of Black women moved during their pregnancies because of problems paying their rent or mortgage, and that was 35% higher than their white counterparts. And that Black women are the group most likely to be the primary breadwinner, and as I mentioned, most likely to be overburdened by housing, which is, again, spending more than 50% of your income on housing costs. So then when we think about, so that's housing, those are our neighborhoods, and then because of those neighborhoods, we know that redlining existed, which was the process of deciding who got to live where, and it has a long legacy on who lives in what neighborhoods. And so those neighborhoods often are places that are considered to be food deserts, which means people have less access to nutritious food and clean air and water, and they're more likely to be placed near freeways and other places where the air quality and other resources are poor or limited. And then if we we begin to think about what else is happening in terms of community and interpersonal violence, in many instances, those neighborhoods are ones that are often over-policed. And also, the experiences of violence among Black women are that they are often both underreported because of our very difficult relationship with the police, and also we are very likely to experience them. And part of that is also tied in with wealth. We know one of the risk factors for increases in domestic violence is job loss in your partner. So you can just imagine what's happening right now, where we have lots of people who are sheltering in place with people who they may have abusive relationships with who have just lost jobs. And what that does in terms of just thinking about what their safety may look like. And then we have to think about, the sort of the social aspects of this, the devaluation of the voice of Black women when Black women are showing up in healthcare settings and other places, being told that their symptoms don't matter, their pain is not registering as being as important as some of their white and other counterparts, and then also being stereotyped as being lazy or dramatic or hypersexual or strong and not receiving the care and attention and support that's necessary. And so when we think about how all of this kind of plays in together, we're really understanding the landscape of how racism and sexism intersect and the negative consequences that they have on Black women's health.
Oh.
So then moving, my apologies, my dog has decided to sit right underneath me and is barking at nothing. So my apologies for the background noise. We're all in this together, everyone. So when we then begin to think about Black perinatal health, right, and looking at women who had a live birth in San Joaquin County, and that's incredibly important to distinguish because live births are only part of the story. We know that our infant mortality rate is higher. We also know that we're more likely to have miscarriages and fetal deaths along the way during pregnancy. So this is already a sample of women who were at least healthy enough, and their infants were at least healthy enough to make it to birth. And when we look at some of the rates of conditions that we know are associated with that are both chronic conditions and are also associated with poor health status over time, we see that the Black women who gave birth in San Joaquin County had asthma rates that were almost 23%, which was 30% higher than their white counterparts. The obesity rate was 30% higher than the white counterparts. Our food insecurity was 20% higher than our white counterparts. Our intimate partner violence during pregnancy was 2.2 times higher. So that's 220% higher than our white counterparts at 20.5%. When it came to smoking, right, it's 70% higher than our white counterparts. Prenatal depression, which we know is not necessarily linked to postpartum depression, but certainly is a risk factor for it, and that's 80% higher than our white counterparts, with almost a third of women experiencing prenatal depression. And then our unintended pregnancy rate being almost 50%. And unintended pregnancies are just defined as mistimed or unwanted. So these are women who are either saying, I didn't want to become pregnant then, or I didn't want to become pregnant at all. And that is, again, 90% higher. And so when we're thinking about how all of that kind of comes together to shape the experiences of Black women, we recognize also that, another important piece of data to consider is that almost 30% of women became separated or divorced during their pregnancy, which is six times higher than our white counterparts. So when you're thinking about the stressors that are happening during pregnancy, we're more likely to have to move because of job loss. We're more likely to lose jobs. We're more likely to separate from partners. And then in addition to that, there are a whole host of chronic conditions that we're more likely to experience. And so that really is the untold story of what's happening during women's pregnancies. That when we talk about this, we're talking about access to prenatal care. And I'm always reminding people that the things that make us healthy are not the 15 minutes we spend with a doctor. It's everything else that's happening in our lives that contributes to our stress, that triggers our traumas, and that shapes the wellness or lack thereof that we experience. So lastly, I want to talk about the piece that is really the conversation I think we're really starting to have, which I'm glad about, but it has been disheartening to watch these disparities, especially when I worked at the Department of Public Health. They were increasing, and we were not having this conversation about how important this was. We were still mostly focusing on infants. And even when we've seen the infant mortality rates decline, we haven't seen the exact same gains for women, which is why I made that important distinction up front that they're related, but they're not the same. And so Black women continue to experience 3- to 4-fold higher risk of pregnancy-related death. I'm going to say that one more time because I don't think that's a headline, and yet it's not a headline, right? Black women continue to experience 3 to 4 times higher risk of pregnancy-related death. And that's even if you're looking at the chart on the left, even when we've had declines overall in the Black maternal mortality rate, we have not changed that disparity. So we have also seen similar declines in the white rate, which means that we're still holding fast at somewhere around 3 to 4 times higher. And the big thing that's come out of this, and these data are coming from the Pregnancy Associated Mortality Review, which is looking at all of the women who die within a year of giving birth, and then filtering out those ones that were not related at all to pregnancy sources. So that would be things like, a car accident or, something like that was completely unrelated to the pregnancy, especially if it happened far afterward. And then looking at, what are the leading causes of death and how many of them actually could be prevented. And we had a panel of experts that came together to actually do some medical review to be able to talk about what could we have done differently to save lives. And so cardiovascular disease is a leading cause of pregnancy-related death, which is important if you consider the obesity rates, and I didn't present hypertension or diabetes data, but those are also higher even in our young women who are in the birthing population. But what is striking to me is that 41% of the pregnancy-related obstetric deaths had a good to strong chance of preventability. So that's not even getting into all the social and contextual factors that we just talked about who lost jobs and who had less money and who had more chronic conditions. This is just saying that if we had managed something different in the healthcare system, 41% of those women could still be alive. That is a stat that haunts my dreams and haunts my daytime experience as well, because that means these are lives lost just because we didn't do enough in the healthcare system, which is the smallest piece. It has the smallest impact on the number of women who are negatively impacted. And so the big thing that we have to recognize is that there are multiple ways and and multiple factors that played into these pregnancy-related deaths that are absolutely modifiable. And so I know that this was not the uplifting and rah-rah presentation that makes you feel good, especially while we're also facing a global pandemic. But I think the big takeaways here are that we can't have a conversation about Black maternal health without really being clear about the lived experiences of Black women and the structural ways that misogynoir impacts our lives, and that we also have direct action steps from healthcare all the way to how we structure society that can make a major difference in preventing this. And that when we are faced with obstacles, that's the part we really want to hold on to and remind ourselves of. So with that, I want to turn it back over to Erica to moderate some questions.
Well said.
That was amazing, Dr. Flo. Just so many things to think about and to consider. Do we have any questions from any of our audience? I know Ms. Sheila James was saying that she's just reflecting on the intersection of IPV, depression, and unintended pregnancies.
Absolutely. Yes. And we have to recognize that, those experiences of intimate partner violence during pregnancy often have roots prior to pregnancy. And we didn't even get into a conversation about reproductive coercion. So, how many of those were also birth control tampering or pregnancies that were not entirely consensual?
I have another one coming in from Alicia Barnett. She's saying, what can we do or what is being done to lower these numbers?
Absolutely. That's a really great question. Some of the work that has been done at the state level, because it really is challenging to do, the case review at the local level because the numbers are just so unstable and there's so much happening. But what's happened is the California Maternal Quality Care Collaborative has actually taken some of those leading causes of death where they saw major issues with preventability and actually come out with some toolkits that include what we call hard stops. And what that means is that you are required, if you are the physician, to actually get administrative approval to do something outside of the protocol. Because one of the things we recognize is that it's really important to talk about race. It's really important to talk about racism. But when we allow people to use discretion, they bake in their racism. And so when we have protocols in place that say this is how we do it, and you have to come up with a really strong rationale not to do it that way, we see people giving the better care to Black women. And so that's the part of the equation that we constantly have to talk about, is that we talk about racism, but then we eliminate your opportunity to institutionalize your racism and your biases by having protocols in place that you have to have a good rationale for going against. So that in the healthcare setting, that's one of them. When it comes to, the policy opportunities, and I know we have some really great panelists that I'm looking forward to hearing from, but the policy opportunities are looking for the window. It's kind of like, I'm sure many of us double dutch growing up, right? And double dutching is all about finding that time to get in the rope, right? And the same move, but hit at the wrong beat, will end up with you getting whiplash on your face, right? And so the same thing is true here, and I'm hoping that that the upside of COVID-19 is that we're actually being able to see all the possibilities, right? In a matter of weeks, we've gotten eviction protections for folks. We've gotten cash aid out to families that need it. We have loosened restrictions on who can get food, through SNAP. I mean, we've done a lot in a really short period of time that everybody thought we're years away from this. We now have, millions of Americans who recognize that maybe their health insurance shouldn't be tied to their employer because they just lost their job in the middle of a pandemic. So I think part of this is in some ways being opportunistic and taking advantage of when things are bad to be able to highlight. Remember that stuff we were telling you about 6 years ago? Well, it's still important now, and here's why. And so that's what I see as the policy opportunity is the vulnerabilities everybody's feeling right now, we are feeling them more. And so being able to highlight that and use it as a way to double dutch our way into the middle of the rope and start doing our tricks.
I love that analogy. That's awesome. That's really great. And if we don't have any other questions for Dr. Flo, we're going to move. And thank you again so much for that review and analysis. And I'm going to remember that analogy of double dutch. We're going to jump our way into this. Okay, so now I'm going to introduce briefly the other panelists that will be joining us. And I'm hoping that we'll be able to get to as many questions as we can. There's a possibility, I think we may be able to go over the time a little bit, but if not, we will just get through as many as we can. So next we have, let me go back. We have Ganesha Boyd, who is a native of Stockton, California, where she currently resides with her fiance and 4 children. Through her life experiences and upbringing by her grandmother, she has developed a passion for the community and social justice. Continuing in her family legacy, Ganesha is an entrepreneur, advocate, activist, and leader who strives to empower all for the betterment of her community. She has worked with organizations such as Head Start, PACT, PICO, ACLU, and NAACP. Her recent birthing experiences and history of mismanagement by healthcare professionals sparked a desire to share her story to bring light to the need for change in the healthcare system. Through the support from a local nonprofit organization, Flourishing Families Incorporated, Ganesha is working to become a doula, a breastfeeding peer counselor, and community health advocate. Her goal is to empower and bring awareness to those who suffer from the same adversities in healthcare and help to decrease the Black maternal infant mortality rates in her community. Maternal and infant mortality rates. And we also have Dr. Aisha Kristina Hunter, and she is a licensed marriage family therapist and a counseling psychologist. She has been an employee of San Joaquin County for over 21 years. Dr. Hunter specializes in treating individuals with trauma histories, depression, anxiety, and psychotic disorders for over 15 years. Her work history includes working for public health, where she has served as the teen parent population. Thereafter, Dr. Hunter worked as a social worker for Adult Protective Services, where she investigated elder abuse, and now she serves as a clinical supervisor and mental health clinician for Behavioral Health Services of San Joaquin County. Dr. Hunter provides psychotherapy for the lower socioeconomic class of individuals who are currently on welfare. She has been devoted to helping the underprivileged and the less fortunate for roughly 2 decades. Dr. Hunter is a proud member of the prestigious sorority Gamma Phi Delta, where she is dedicated to promote education and community service to the youth, the needy, and the general. Dr. Hunter is currently happily married and has 3 beautiful children. She's an active member in church, and she is trained as an eye movement, desensitization, reprocessing, and wellness recovery action plan. That's a word wrap. Dr. Hunter has written 2 published works. She has written an article for a scientific journal published in March 2016 and several other journals as well. So thank you, Dr. Hunter. And moving on.
Thank you.
And we also are joined by Ms. Sandra Merriweather, who is the wife of Michael Merriweather, retired NFL linebacker for the Pittsburgh Steelers, Minnesota Vikings, and Jets and Packers. She's an author and a member of the Off the Field Players' Wives Association, and she has found her love and passion in comforting others to a life of health and wellness. She began her career in the medical field at the age of 15, and at the age of 19 was a respiratory therapist. She continued to advance her career. And she began her registered nursing career working in multiple hospitals in San Francisco area, including Rapid Care and St. Joe's Hospital. She's currently works as a San Joaquin County Public Health Services nurse, and she's a public health nurse for the Maternal, Child, and Adolescent Health Program and the Black Infant Health Program, serving pregnant women to achieve healthy, successful birth. And lastly but not least, Tamisha Valverde is a board-certified lactation consultant and community health advocate. She has worked with expectant and young families providing direct services through Delta Health WIC program for over 17 years and is the co-founder of Flourishing Families Incorporated, a nonprofit that works with Black families in the community. She is the only African-American lactation consultant in San Joaquin County and facilitates a weekly African-American breastfeeding support group where she provides group education to pregnant, breastfeeding women and their families. She is known for her passion for Black breastfeeding and collaborating with local organizations such as Black Infant Health Program, Breastfeeding Coalition, local hospitals, and public health advocates. So I'm going to go ahead and have us get started for time's sake, but thank you and welcome you all. Yes. Okay, so our first question, and I want to make sure we get these questions. So, well, this one I thought you would really resonate with. So based on the data showing the intersection of racism and sexism, how does it negatively influence and how it negatively influences care for Black mothers? What are ways that this information can be integrated into care by providers?
I would like to start by saying that the information that was presented by Dr. Flojan Kofer was really heart-moving. And working for the Maternal, Child, and Adolescent Health Program and the Black Infant Health Program as a public health nurse, I've seen so many different things. There are so many different ways that we can help and, curb the infant and maternal mortality. Some things that I thought about was that we need to educate the clients about early prenatal care. That is really important, and I don't know how much we can stress that, but early prenatal care is very beneficial. We also need to talk to our women about preconception health. Like if they have any chronic diseases or infections, they need to get those things taken care of before getting pregnant, So preconception health is another thing that is very needed. Also, during thorough assessments of our clients' current health status, that's also vitally important because knowing what chronic diseases that we have and knowing what is actually going on right now and not avoiding women's complaints. Because I noticed that in a lot of African American women, their complaints are avoided and not taken seriously. And because we are women of color, sometimes signs and symptoms don't get as recognized early on. Like we change colors and we may be ashen instead of just going pale white. You have to go back to, like nursing 101 and know your signs and symptoms backwards and forwards. Notice if a client is not communicating with you well. Notice if her ankles are swollen and she's complaining of, edema and she's not feeling right. Listen to her when she says that her heart is skipping beats. Listen to that, because that's significant of something's going on with the heart. There are so many things we could do. We have to actively listen to their complaints. And we need to encourage our clients to engage in effective communication with their provider. Communication is really important, but we must also understand that our providers, not all of them are racist. And a lot of times they'll go into a room, they only have 15 minutes to actively engage with us. So they got a lot of things going on in their head. They're looking at these assessments and they're thinking about the lab results. They're thinking about all these different things that they need to do within this 15-minute time period. So if you show compassion and engage, they will also engage and show compassion to you. But if this is not happening, there are things that you can do. You always can get a second opinion. We have to be our own advocates, but some other things that providers can do is raise the quality of care due to increased disparities and traumas that our clients may have. So we know that they have trauma and we know that they have these things going on. That means that we got to bring our care up to another level, okay, to see where they really are. We need to currently assess their health status. We need to obtain a thorough health history and assess for barriers in care and treatment. These are all vitally important. Assist clients and provide referrals. When we don't know the answer, we can go to our colleagues, because this is not going to get done with just the provider alone. It's going to take all of us. This is a community-wide effect that needs addressing. It's going to take people from WIC. It's going to take people from the state. It's going to take public health advocates, flourishing families, the police department. We all have to take, I'm a missionary. So when they say, do what your hands find to do, that's what you got to do. Do something. Be caring. This is a time of COVID, but this is also a time to show love and respect for all persons, okay? So we need to also be able to teach our clients coping mechanisms, and that's what we do here in Black in Health. We have mental health provider here, a mental health clinician here, and we also have our family health advocate, and then we have our facilitators. And they work so good together in doing all of these in our prenatal sessions. And so we have to refer out to our behavioral therapists and do behavioral interventions for those women who smoke, who use drugs. We have to look at all those things, because all those things can hurt them as well, and alcohol. We need to note obesity, because that leads to complications as well, and preeclampsia. I can go on and on and on and on, because this is my passion. I enjoy working for public health because it's taught me a whole lot. But like I said, I could go on and on, but I'm going to leave. I had 21 things like that song 21 questions or whatever it is. I have 20 facts listed here that we could do, but we just all need to do this as a community, and really get involved.
That's good. I really appreciate your passion. I'm going to move on to the next question unless anyone else had anything to say.
I just want to chime in a little bit, Dr. Hunter. I just want to expand off of what Ms. Merriweather indicated. In adding on to that, we have to equip the population to be able to know how to advocate for themselves. And I know we're going to address that later in some of the upcoming questions, but a lot of them don't even know how to articulate what the problem is.
Mm-hmm.
They don't know how to even determine when and how to even address the issue. So they have to be educated and equipped and supported in order to be able to do so.
Mm-hmm.
It's kind of like that saying, a closed mouth don't get fed.
Mm-hmm.
We need to, and she also mentioned, Ms. Marietta mentioned about teaching them coping skills. We have to definitely teach them how to find their voice so that they can even reach out to know that they need the coping skill. A lot of times we as Black women, we have that image of we're strong and we know what to do and we're doing the best we can. And we think that we are doing the best that we can when there's many opportunities to learn and grow and improve. And then there's a part of us that don't want to even to admit that we need help. We don't want to, because it will be considered a sign of weakness, which contributes to the stigma that's already out there about Black people coming to get mental health support. These are all these issues that plague our people. And these are the barriers, the stigma and all the myths that are associated we have to break through. And these are the things that prevent people from finding their voice. Mm-hmm. These are the things that prevent people from even recognizing that there is a problem because their defense systems are up. Defense system, which requires them not to see their vulnerabilities because on the pretense that they are strong. So we don't have no time to be identifying what weaknesses we have. We're trying to make it day to day. You feel me? Mm-hmm. And that's what's going on. These are the barriers. These are the things that we're up against. And then when there's this Black woman who feels this way, just like how I'm describing, goes to the doctor and they have all those things, they're not going to speak up and talk to the doctor because of those things as well. So we need to equip our people, our Black women, to find their voice. And Absolutely. To educate them about truth, that it is not weak to go and get help. Actually, it's a sign of strength. It's a sign of willing to advocate for yourself. And it doesn't just affect you, it affects your kids and the generations that come after you. You are leading the way. We have to equip our women that they are leading the way. Any intergenerational curses or anything that can be broken with you stopping, recognizing the problem, and leading the way.
Also, I would like to add on to that as well. We have to, I would say we have to learn how to document everything. When you're going into the doctor's office, you need to write down what that doctor instructed you to do. When you're phoning someone, you need to document who you spoke with. And that's another thing that we've gotten far away from is documentation. We as the Black community, we don't document as we used to. Like, I remember my grandmother telling me from her era, they used to contact their local statesmen. We don't do that anymore. We're in an era now where we're taking things into our own hand, and it's putting us in a sicker state because we're becoming closed-minded and we're closing up and becoming more defensive and creating defense mechanisms versus being proactive in creating solutions for our problems.
That's great.
And I just want to add one quick thing, and then you can move on. Hi, everyone. The emphasis on community collaboration between agencies and connection with resources. I think that that's really important and vital because the physician doesn't necessarily have more than 10 to 15 minutes at a time with their patients, and we're all limited and sometimes with our time. I think it's really important that we don't just hand a referral over or just tell the mom to call this place and you'll get these services. I think it's really important we communicate amongst each other and we can do soft handoff so that we can make sure that that mom actually connects with that resource to the right person, and so the continuity of care does not stop. It's something that I do a lot with the Black Infant Health Program and the WIC program and other community organizations, and I think that it's vital. I think that that's vital to the success and for the health of our family. So just to emphasize that.
I also think that an equally important intervention for care providers and workers in the community is to also receive bias training, to raise awareness. I think this is vitally important as well, and to promote advocacy movement. Also, I think that if we learn how to conduct our own research to identify the best practices, and inform our clients on how to do so. We have to do a lot of teaching here. It's going to take a lot of effort, but we're saving lives. So I would do anything to save a life, won't you?
Absolutely.
Mm-hmm.
And leading into that, I want to get into this next question, which is dealing with, that very important fact. So there are countless articles highlighting the experience Black women face, the vulnerability and powerlessness that they express when interacting with hospital or clinic staff. How has the COVID-19 pandemic further illuminated and support the maternal health inequities faced by Black women and families in this country?
You're muted. Well, I personally, from friends and family that I've spoken to and community members, I've heard some horror stories. Women withholding. Well, I'm not going to say they're refusing to go to get services because they're afraid of the whole situation with the COVID-19. They're afraid that if they are in a space with people who are quote unquote asymptomatic, that can be passed down because of the lack of knowledge they have on the situation, but also too the scare tactics that are being taken place in the media. Mm-hmm. So there's not a lot of Black physicians that are accessible right now, and physicians on period because of the situation. So the healthcare professionals are kind of not accessible, so people are going towards the old school remedies in a sense, but at the same time, it's not that effective, especially when you don't know if your child has a heart murmur, a disability, or different things to that extent. So people are taking a lot of healthcare remedies into their own hand, which is not really effective. And it's sad, but I know a lot of people are dying because they are sick, but they don't have the proper health care. Yeah, health care is accessible, but at what cost? Because everybody doesn't qualify for social services like wealth, Mm-hmm. And so in our community, it makes it hard and difficult, and it becomes a barrier because everybody doesn't want to be a quote-unquote statistic, a person of the welfare system. Mm-hmm. So I think that creates a barrier between the gaps that we've been working so hard to close with the connection with community services and doctors and healthcare providers.
It's really good. Yeah. Anyone want to speak to? Okay.
Yeah.
Dr. Hunter.
I would, Dr. Hunter. So I wrote down my answer to this question when I got the questions, and the first thing that came up for me is what I've noticed that since this COVID-19 problem has been going on in our society, I look at the mental health behind that, and I've noticed that, and other clinicians have also agreed with me, and that being quarantined and not having to work outside the home and being about a busy lifestyle is forcing individuals, unfortunately, to deal with their unresolved issues. Okay, mm-hmm. To deal with their trauma, their abuse, and we know in And we know recently, 2 weeks ago, Stockton record indicated that the Stockton Police Department said that domestic violence has increased since COVID-19. So people are home dealing with one another. There are unresolved issues of trauma that's coming up, things being triggered. Children are witnessing the things going on with these adults in the home. We have children committing suicide, right? We have, it's an all-time problem with the mental health because of what's going on. And who are these people reaching out? Who are we reaching out for help? You know, who are we talking about? We're trying to deal with these things ourselves and trying to manage the best way we know how with limited access to the support that Sister Carisha just brought out a minute ago. So you see what I'm saying? It's really having, and these are things that are unspoken. So I'm so grateful to this platform that we're able to talk about it. As a therapist myself, I'm trying to get even our clients to call in and to be open to receiving even phone therapy. We're not in the county. We're not allowed to do face-to-face right now. So, but we're allowing ourselves to be able to reach our clients via the phone. But we need our clients to reach out to us to say, yes, I want this help, and we're still there to provide them with phone therapy sessions. But who's doing that, you know? And so I was hoping that this platform will also open up the opportunities for people to get this information and knowing that they don't have to go through this alone, that we are here. Trained professionals are here to support. We're here to support our community. We're here to help them with being able to deal with the stress and the anxieties and depression and trauma, all these things that are coming up because of this quarantine situation. So, but that's what I wanted to ask.
I wanted to also add a number where clients and individuals can also refer people, and that is the Consumer Support Warm Line. I have used them several times for my client here with the San Joaquin County Department of Behavioral Health. Their number is 209-468-3585. That's 209-468-3585. And they can help a client if they just want to call in and talk anonymously. So you have someone else that you can talk to in the middle of the night if you need to. And you don't have to, tell them who you are. But if you want to talk things through, they're there to do that. They also can help you with in a crisis situation, if you're in the middle of a crisis situation. A lot of times clients have issues and they'll call 911 and then the police come and they take them to jail. This bothers me. Going to jail is not the right place. They need to go to get help. And this is why I am so emotional about this, because they need treatment. They're not criminal. So call this Consumer Support Warm Line. They're there for you.
Can I add something on that? Thank you so much for that, Sandra. What police and oftentimes even certain healthcare professionals are failing to see a person have been activated their sympathetic nervous system, their stress response, right? Nurses, doctors, we know about this. The stress response can go into that fight or flight mode, and they're seeing the fight mode, and they're determining that this is intentionally being oppositional and defiant when people are reacting to the stress, the trauma that's in their body. And it's commonly being misunderstood and misinterpreted as this intentional, defiant, unruly behaviors. And it is not. It is pure mental health that's being, displayed and showing that a person is going into that fight response when it's not intentional. It's a reaction. It's a reaction to the trauma, to the stress, the things that are going on not only within the home, within the environment, within the system, the experiences being pulled over and discrimination and the prejudice. It's a reaction to those things that we have witnessed in our communities and have gone through. And yet we're so quick to judge and determine that it's maliciousness.
Can I say something about that? Through my advocacy experience with people with mental health, I was a former autism specialist as well. So I've seen several different layers and different people on different spectrums of autism, mental health, family experience as well. I had a client and she was having a nervous breakdown. They came in, she barricaded herself in the home. The police came into the home. They weren't even equipped to deal with this. But they did say that she had broken some laws, so they took her to jail just to get her, to confine her, to get her out of that space. So there are always ways for, like Dr. Coffer said, for racism to come in and to creep in when they're able to use their form of discretion, like Dr. Sandra. So minimizing those ways for them to use their discretion. And there's no backup system because there's no system implemented for mental health as we speak in 2020. So knowing that domestic violence is rising due to the COVID-19 and isolation, what do you guys think can be put in place as healthcare professionals, and especially you, Dr. Hunter, you being a psychologist, what do you think should be done in the community to help actually protect those people? Because a lot of people that wouldn't normally be labeled as mental health clients are conforming. You know, as a mom, sometimes I have to step back and think, like, am I having a nervous breakdown? Have I been in the house too long? I have to step outside at night when the kids go to sleep and go get on the phone just to play a video game or to de-stress and think what I did for the day and where did I go wrong and what we didn't accomplish, even though we don't have nowhere to go. So I'd like to hear from you guys about that.
I could definitely answer that, but I'm wondering if anyone else wants to also chime in. I don't want to dominate the conversation.
No, you're fine. You're fine.
Go on. Okay. Well, as you were talking, my dear, I was thinking that we got to get the information out to them that the help is there. So the question is, how do we do that? I'm not sure. I'm not sure how, but I know this is a beginning. This is a start for us to be open and talking about this. We're talking about the problem. We're talking about the results of what's going on. So we got to get this information out to the average Black citizen and let them know that there are systems in place to support them. And people like me who have a heart who are so willing and so dedicated to help people. I've spent all my education trying to figure out how people work, how we think, how to help people. And I'm serious about this, you know. And so we have to let them know that we exist, we're here to help, and that there are mechanisms in place to address these issues.
That's good.
Yeah. And just to kind of chime in, I think just talking about this specific aspect of this question with connecting with resources, I think we need to revisit how we connect people, because we're so used to that face-to-face conversation, and we need to use our social media platforms with our different organizations. We need to communicate better amongst each other to make sure, again, that we can have that soft handoff that's needed. I even recently, I know Nurse Sandra, she sent somebody my way just for lactation support, and being able to hand her off in that way, as opposed to, like I said before, here's the number, call this number, but more being able to get that information to them as they're receiving services from our other organizations as well. One of the things I wanted to touch on in this question, because I know we have to move on to the next, is just highlighting the mistrust in the medical system that already exists in the Black community, and just how this pandemic has kind of intensified that and perpetuated that, especially with the inconsistent messages that we've been getting. There's a lot of misinformation about COVID out there, even from our government. And so because it's inconsistent, we don't know what to believe. We don't know what's correct and what's wrong. And so even in my profession as a lactation consultant, I'm dealing with a lot of misinformation when it comes to, whether or not I can breastfeed my baby. Women are making decisions that are fear-based when they're talking about how they're going to birth, or, also how they're going to feed their children. So I just want to make sure that if I have to be away from my baby can eat. So I want to, introduce formula early on, or I want to make sure, if I'm going to be separated from my baby, that the baby has what they need. The other thing that is happening just in the medical field, when a woman is birthing, whether they're COVID positive or not, if they're person under investigation, there is this fear as to how they're going to be treated in that system, and so whether they're going to be separated from the baby or not, who's going to be their partner that is going to be in the birth with them, because they're limited, right? And we're used to having our support systems there, our mother or partner or whomever we choose to have there. And very likely a lot of these women are going to be birthing, might even potentially birthing alone. And that's scary and that's traumatic. And it adds a whole nother layer of trauma on top of the trauma that we already have existing prior to COVID, or even sheltering in. Imagine a woman sheltering in for that length of time, and then maybe dealing with domestic violence, and then she goes into the hospital to deliver, is only told she can have one person or limited, and maybe be having to birth by herself, and then having a negative birth outcome. Maybe she ends up delivering by cesarean, right? Oh, you have some symptoms of COVID, so now we have to separate you from your baby. So there's just so many layers to it that this pandemic really affects maternal health. Just one quick example. I had a mom that delivered early, because that African American women, we have higher preterm delivery rates, right? So I had a woman that delivered early. Her baby was 35 weeks, actually, with twins, 35-week-old twins. Delivered early. They were fine, but she ended up delivering by cesarean birth and ended up having to be discharged a lot earlier than I would expect with a cesarean birth, which is less than 72 hours. Without established breastfeeding, without a breast pump, without any additional support outside of a doctor's follow-up 2-3 days later. So here we have these babies that did not stay in the NICU and came home with her. To God, Lord knows what is going on at home, right? And then without adequate support. So that's why I say it perpetuates the already pre-existing issues, right? The already existing traumas, and then them not getting the support that they need.
Absolutely. Thank you so much. But I want to move on. I'm going to come back to that question if we have time, but I want to move on to this one, and then I'm going to take a question just in case we get cut off. I think we should be good for time, but just in case. So what are some key phrases or questions that Black women can use to signal to healthcare providers that they know their rights and know how to advocate for themselves and also for their partners?
I would like to say that I want to give an example. About 3 weeks ago, I had hurt my knee, and because of all the COVID, it was hard for me to get in to see my provider. So once I finally got in, my provider referred me to a specialist, and I have very good doctors, communicate with them. They know I know my stuff, so they'll do whatever they can for me, okay? But when it was time for me to get my medication from the pharmacy, they told me they didn't have the medication in the building. They didn't have any, and that the medication they needed for the COVID people. They need the antibiotics for the COVID people. So it was on back order. So I said, okay, I need my medication. I've been limping around for 3 weeks on my job. Everybody sees me. So I said, okay, I'm going to ask these people, let these people know that I'm a nurse. I had no other choice. And I said, I'm a nurse. And that's all I said. I didn't say what kind or nothing. I said, I'm a nurse and I need my medication. Do you know where I could get some? So then at that point, they gave me not one, but 2 pills. 2 pills out of an order of 30. I'm supposed to have 30 pills. So they lied to me when they told me they didn't have it, and then I get 2 pills. And then I said, okay, I'm going to have to think of something else. So I got home and I said, I called them and I said, can you call other pharmacies for me and see if anyone has it, and then you can send my order over there and I pick it up. They had me going back and forth between these 2 pharmacies who might get some. And then I told them, I said, okay, this is just like what everybody's saying. Wow, I can't get my medication. I've already told you I'm a nurse, but you know what? I forgot to tell you that I'm also Black. So I really need medication.
Right.
Guess what happened? They fulfilled my medicine in 20 minutes. I got my full prescription, and I'm here today at work walking with no limp, no nothing. I know that is the Almighty, you know. Sometimes we have to go back to our culture and go back to prayer. I'm just saying. But, you know,
Amen.
I'm an advocate for my health. I was an advocate for my parents' health when they died of heart disease. But what do we do for our clients? They cannot advocate for themselves. So
That's what I'm talking about.
Is we have to teach them how to navigate the system, how to get the things that they need. And then we need to teach them, if you're unable to, is there an adult in your family? Is there an aunt, a grandmother, an uncle that can help advocate for you? Are there health providers that can advocate for you? So this is a very important thing. We need to teach people, you know, how to advocate, navigate, coping skills, all that, and some.
Good.
What I will say is, when I was going through my situation, I have 4 biological children. So my last son, he's the one in my arms, he's 6 months, but I have a 2-year-old. So with my situation, I had to really work through the whole community. And I had a situation where I had a surgery at the hospital. I was very distrusting of the hospital after my situation, coming to find out I was still pregnant after they told me I was no longer pregnant. So my first mode was to contact every Black resource I could find, which is very limited here in San Joaquin County. But my first call was to WIC. I called Misha first. From Misha, I went over to Black Infant Healthcare. She had already called ahead. She had already written out who I needed to contact. From there, I met with Nurse Sandra and all the Black Infant Healthcare staff. So I was jumping around, but I went into, I was being reactive to the situation, but also too, I knew that I had a larger distrust for the healthcare community, so I needed to get as many people that look like me as possible for me to get an educated opinion on what my next move should be and how I should maneuver. And from that point forward, I looked for every possible Black doctor, not because I'm racist, but because I need someone to understand what I'm going through, especially in a time of mourning. I had just lost a baby, and I was pregnant with twins. And then I felt like I was having a mental breakdown. So from there, I was able to talk to some of the therapists. You know, a lot of Black women, like they said, we play this strong role until it hits us. And then we break down, and we don't understand why we're breaking down. And it's not just because that one instant, it's the instant that we're at that moment that triggered all these other things that we have been harboring. So from that point forward after experiencing that traumatic.
Can't hear you.
Can't hear. Yeah.
You guys can't hear me?
I can hear you now.
Say it one more time.
Okay, the baby. But I had to when I told the doctor that, hey, my amniotic fluid, and I think I'm in labor. Oh no, you're not. You're just peeing on yourself. Only to find out my amniotic fluid was broken. When I was going into labor, I was with nurses. I was leaving my Black and Healthcare class, and the whole staff was like, Krisha, I think you're in labor, and I'm like, no, I'm fine. I'm about to go home and walk it off and take a nap. They was like, no, leave your keys here. Had I been somewhere else where I wasn't trusted, I probably walked away and probably had a miscarriage trying to hold on and be strong, whereas I was in a program with 4 or 5 strong Black women that could actually relate to me not only professionally, but, from personal experience. And these are all Black women who can actually, relate to me in some form or fashion. We might not have all the same upbringing, but we can,
we can definitely relate.
We can all relate to each other in some form or fashion. So, I had to start exercising. They didn't want to let me feed breastfeed my baby in the hospital. I had to call Tamisha. Tamisha had to call down to the NICU, and then the lady was running down there. I am so sorry, but had I not had those resources, utilized those resources I had, then I would have been. I probably would be a mental case right now. I'm not gonna lie, because it was a lot coming on at one time. I had a premature baby. My baby had to stay in NICU. He stayed longer than I stayed in the hospital. So did my 2-year-old daughter. She stayed longer. But if I wasn't equipped with the proper team, and that's what I'll say, I had a team going in. Nurse Sandra sat down with me, did my birth plan. Misha went over my birth plan with me. Make sure you let them know when you're getting ready to breastfeed, you want your baby breastfeed. I had a situation. I had an asthma attack in the NICU, and in the midst of me having an asthma attack, they told me they was going to give my baby formula. I must have almost passed out, and I couldn't even catch my breath. So imagine your eyes bulging out and like can't breathe, and you're going to give my baby some formula. So it's just, with my personal experience and all I've gone through on 4 different pregnancies and births, I would say it is necessary for you to get a team together. Not only you want a family member involved or a friend or a community member, but you need some professionals. And we need more professionals that look like us that we can trust.
Yeah.
You really nailed it, Krisha. I really think it's great. It's not just key phrases. It's a team. It's a team, and it worked for you because you had those systems in place. You knew, I see a lot of continuity happening here. You call Tamisha calls the NICU nurse. You had a team working for you. So that's amazing. Thank you so much. I want to
just really quick, Erica. I'm sorry. Just really quick. I just want to piggyback off what she was saying. Because the key thing for her about providers that she reached out to was that they were the type of people that would hold her hand until she was able to advocate for herself. And sometimes we as providers need to understand that we have to hold their hand until they're able to know that it's okay to advocate for themselves, or to learn the skills that they need to be able to advocate effectively. And not just say, well, here's the resource. I keep saying this because just giving them just a resource is not going to solve the problem. Our women need support, and support looks different than handing off a resource. And I just want to emphasize that.
I like that. I agree.
That's so good. So kudos to you. Kudos to the team and to you, Krisha, for knowing you had a team and somebody and several folks that could work with you, and for Tamisha for activating her team and working on her and working to advocate for her. just in case we do get disconnected early, I'm just going to do one or two questions. So from Leisha earlier, Leisha Barnett asked, sometimes when you are with a provider, they give a lot of information at once, and without a follow-up, it makes it difficult to identify the proper resource for the individual, especially because they come and see you. They come and see you in high stress situations. So I think she just, just a comment about when we were talking about, I think, Ms. Sandra, you were talking about, you're getting a lot of information at once. They only have 15 minutes, 10 to 15 minutes to talk to you. Mm-hmm. Absolutely, that's really difficult. So that was more of a comment. There was a question from Patricia Miller. She said, thank you to, I think she meant Carisha and Tamisha. Can you talk about asking and inviting 3 generations of Black women to have a conversation? I think that would be great.
Mm-hmm.
Absolutely.
Absolutely. I know that. Oh, can I say one thing about flourishing families? I just wanted to bring up, we did a few months back a Red Roundtable talk, which was a platform for the generations to come and have conversation. We actually had an event with Kimberly Sills Allers that came out, and she facilitated the discussion. And so I think that more of those are needed in our community. I can't agree with you more. It was Patricia Miller? Was that who it was? Yeah. I cannot agree with you more. And so we definitely need to work together to make that happen. One of the other things that I have done with public health advocates, is working with them with breastfeeding, is I've actually done some trainings where I actually bring grandmas in and talk with them. It's centered around breastfeeding because that's my profession, but how important it is to have them come in and have a conversation with their daughters about how they can support. And so generational conversations are much needed because we don't parent in a silo. We don't birth in a silo. We birth in a village, and our village needs to be on the same page as us and need to be aware of this, aware of the things, the traumas, the risk factors that we face as Black women to help reduce the rate for our mortality.
Mm-hmm. That's really good. And I'm gonna go back really quickly to that. Oh, it's gonna send me through. Okay. And I thought this is really important too, as we're talking about just how this makes all of us feel. And we talk about BMMA's, their goal this year to talk about centering moms. Sometimes it feels like no one cares about Black mothers, interpersonally, community-wise, systems-wide, and just from you all's experiences that you've even shared today. How do we deal with these feelings of hopelessness or powerlessness? And I would direct first maybe to Dr. Aisha.
How do we deal with the feelings of hopelessness and powerlessness? Again, what comes up for me is that goes back to the importance of speaking out and voicing that you feel hopeless, voicing that you feel powerless. It's about getting past those defense systems that are within our bodies that are used to, and are within our mind that try to keep us coping and dealing with the situation. We got to get past that, because a lot of times that denial is so powerful, it will prevent you from even speaking out and recognizing the vulnerabilities that you have. Also paired with the beliefs about us being strong women and all that's associated with that. Those are the things that prevent a person from identifying that, hey, you know what, I do feel hopeless. I do feel powerless. And we have to be able to build rapport and trust in relationships, so where even if they're struggling with identifying that they're going through this, that they have someone that they're available to say, hey, I didn't want to say this, but I am really struggling. And so when we do feel like we can trust someone, like Carisha felt like she can trust Tamisha, she can trust the people that she's had, a relationship that it causes a person to kind of go beyond their denial and say, you know what, I do need help, and this is what's going on with me. And so how do we instill trust into the minds of the people that are out there? That's the question.
Mm-hmm.
And I think, just to kind of piggyback what you're saying, is that I think relationship is really key. And in addition to that, creating safe spaces. I think that's so needed and so important. One of the things that I know you guys heard earlier, that I do a support group for African American women. And so, well, why would you need a separate support group for Black women when, you know, many women breastfeed? Well, the truth of the matter is that, yeah, when many women breastfeed, but we deal with life with a different lens. And so the conversations that we may need to happen in a safe space where other Black women understand what we're talking about. And so I think that when we're dealing with the feelings of hopelessness and powerlessness, or just even talking about mental health, or just, you know, every health in general, we need to have a safe space that we can talk about that candidly, without having to feel like we have to put on a show, or to, you know, like with my sister, with Erica, with Carisha, with Sandra, and even with you, Dr. Aisha, I can actually sit and take my professional hat off for a moment and just be Tanisha and just be vulnerable, because I know I can trust you, and I'm in a safe space with you. And I don't mean like tangible space. It doesn't have to be like a building. I mean like a space, and even in conversation, even, you know, so those are needed in order for us to be able to deal, and even to be able to talk, or to feel that we can.
Yes.
That's so good.
I believe that's been one of the biggest issues in the Black community, especially when speaking about health issues and life issues. You know, so and when it comes to like social services, we've already got these stigmas when it comes to, you know, social workers, anyone outside of our culture coming into our home, being prejudged, not being able to understand the different dynamics and how we function in our household and in our community and in our culture. So, you know, the outlook is completely different. And there is a certain nervousness. I'm happy that they've provided services where they can say, hey, we can meet you outside. And it's my, you know, culturally, you know, if our house is not spotless, we feel a certain kind of way when someone comes in anyway. And let's just be real. You know what I'm saying? But also, too, we want to be in a position, because we do all, it doesn't matter what economic status you come from. We all have a certain level of, can I offer you something to drink when you walk through my door? Some people step it up. Can I offer you something to eat? If I can't do those things, I don't feel comfortable letting you in. Your house may not even be dirty, but you don't feel that certain level of comfort. And especially with someone outside of your community who's able to judge you based off of your ethnicity, your race, your socioeconomic status, these different things. You know what I'm saying? We have people who believe that living from the north side to moving from the south side to the north side means you've come up in the world. You know what I'm saying? And that's just a social stigma that's been created in the community. It doesn't mean anything, because when you go from the south side to the north side, you find out you're living in a higher poverty. Yeah, the sidewalks may be cleaner, but the housing structure is still poor, or just as poor or more poor than where you came from. So these are the different things that come about in our mind. Some things we make up in our mind, but then there's stigmas that, you know, are voiced and created in our community. So we do need to work on some of those things.
I want to hit on a couple of some comments. This one's from Maria Grabowski. She says, it's not just people asking why a Black breastfeeding group. There are people out there who disapprove of Black Breastfeeding Week. And there are also people that complain about the Black Infant Health Program. Their rationale is, if this were a white infant health program, people would be pissed. Anyone want to speak to that?
I think that when people feel that way, that it's from lack of education. When you take a group of people who have been traumatized for hundreds and hundreds of years, they, you know, a lot of people feel like, oh, we should get over it by now, but they don't understand about the genes and how it's embedded in us, how we end up, you know, having some of these problems at present and how it affects future generations to come. It's a lack of understanding, and sometimes it's not just a lack of understanding. Sometimes people just don't want to understand or want to learn. All cultures are different. Everybody has different practices, come from different backgrounds. But what's unique about this situation in the Black community is that our health is affected in pregnancy across all walks of life, whether we're from a low socioeconomic status or whether we're rich, okay? We all still have those birth issues. We all need to be educated upon it and need to take it seriously and combat this problem. This is a problem. And then COVID is just another problem sitting on top of another problem of already depressed people. So what are we going to do about it? We're going to do those 21 things that I didn't get to all the 21, but we're going to do all of those things, and it's going to take our whole community to educate everyone. And once we do this, we can get our families back. We can make our culture grow and expand. Our babies will thrive. Our mothers will thrive. And maybe our families can pull together and work more closely together once they realize and get educated on what is actually happening in the now, right here and now.
And I have to wholeheartedly agree. And the only thing that I'm going to add to that is that we already have broken systems in place, right? Our systems are already broken. They're not, it's set up as systemic racism. So we need to have those spaces in order to fix and deal with, because the system is set up for us to not be healthy, right? So why would you want to be opposed or even be, you know, let's just use the word opposed to something that might potentially help benefit the health of a community? Why? When it's something that's proven. Right.
And also you're hearing from these women not being listened to as well, right?
Yeah, exactly. And so just bringing light to that. Go ahead.
I want to thank Maria for the question, because it gets asked to Black Infant Health quite frequently.
A lot.
A lot. And I really want to thank you for that honest question.
And Dr. Hunter?
Yes, ma'am.
Oh, I thought did you have something to add?
No, not at this time.
That was you. Oh, I'm sorry.
What I like to say is this: America has made it a point to only utilize us as test dummies when it comes to medical breakthroughs, when it comes to the survival of all other people. But when it comes to medical breakthroughs for the Black community, there is no research that you can find that is beneficial for us. And whether it be in a social setting or a medical setting, it's never been done. So yes, it is important for us to have our own communities, our own groups, our own space, safe spaces for us to talk and to build, because it's easy for us to be publicized in the media as, oh, our kids are gangbangers, juvenile delinquents, murderers, all these negative things. But when it comes to the positive of uplifting each other, empowering each other, it's always what are they doing? Now we're suspicious. But it's only when it comes to the positive. So we need to change the stigma they have and the outlook they have on our community. And we have to start within. And that means we have to gather in groups with only us.
Yeah, it's really good. And like I was saying before, sorry, I didn't mean to interrupt you, Tamisha, but it's about what women are reporting, that they're not being listened to. So if no one's listening to me, then I may need to go somewhere where I can be listened to, especially if it's going to help keep me alive and improve health outcomes. And we understand, because the statistics show us that. So got to figure out a way to get somebody to hear me. And if I have to create a space for that, then that's what we have to do. So it's really good. Hoping we have time. I think we have time for one more. So this one really pertains to Stockton specifically. So Black women in Stockton and also nationally have the lowest rates of breastfeeding. And in Stockton, by about month 3, only 19% of mothers are still breastfeeding exclusively. Considering that the morbidity or the near-death misses for Black women are also astoundingly high, how can we better communicate to mothers that breastfeeding can improve maternal health outcomes? Yep, mother right.
This when I read this question, I was like, was she writing this for me? No, to be very to be very honest, because this is something that really is I'm really passionate about. It's just that these rates hurt my heart. These rates really hurt my heart. Let me just start by saying that, because there's this saying that actually it's scriptural. My people perish for lack of knowledge, right? So one of the things, So one of the things that's really profound about breastfeeding in the Black community is that there isn't this information out there that they really know the impact that breastfeeding can have on their own health. You know, we talk a whole lot about the benefit for the baby. We're doing this for the baby. But we don't necessarily bring up the benefits for a mom and have an understanding, and as a community too. There's this thought that, well, breastfeed if you want to, but formula feeding, it's good. Okay, so the exclusivity of breastfeeding actually impacts the mother's health too, and I think that that's something that we don't really talk about. One of the biggest things is prenatal education. Okay, it's really vital and important to talk to moms before they have their baby about these things. They need to know. They need the information. They need to know, because that's when they make the decision. And that decision is influenced by a whole lot of different things, right? It's not just whether I want what's best for my baby, but we need to also let them know this is what's best for yourself, right? The community and your family as a whole. And if we don't give them that information ahead of time when they're in that place where they're making that decision, then they might make another decision, right? So one of the things that Dr. Kofer was mentioning about was the number one reason why, cardiovascular disease, I believe it was. It's the number one reason why women die, right? Mm-hmm. As far as pregnancy-related conditions. Sorry, not getting my words together here. But the reason I brought that up, the cardiovascular disease, is because breastfeeding actually helps to reduce the mother's risk for cardiovascular disease. And I don't think that that's something that's talked about. I don't think that it's discussed. There is a TED Talk that I really encourage everyone to go and listen to for Dr. Bemwa Schwartz. She's another epidemiologist. But she talks specifically about the decreased risk for heart disease. 5 times, what she was saying in that talk was specifically that it helps to decrease the risk by 5 times. Okay, so when you're talking about maternal health and breastfeeding, and you don't bring that up, but we're talking about maternal mortality rates, and we don't bring that up, we don't talk about breastfeeding, we're doing a disservice to our mothers. They need to know that breastfeeding can help them. It actually reduces postpartum hemorrhage because the uterus is toned. Every time a woman latches on her baby, it actually causes the uterus to contract, which helps with toning and reducing the risk of postpartum hemorrhaging. Dr. Hunter, it actually helps decrease postpartum depression because of the hormones that are involved in regulation, right?
Yeah, I just added oxytocin, the wonderful, wonderful release of oxytocin every time that mother breastfeeds. It helps elevate the mood, it creates connection, it releases it into the bloodstream, and it creates a bond, and the mother feels better about herself. Yes, go ahead, continue, Ms. Tanisha.
Exactly. Also, there's that benefit of postpartum weight loss, and it's not just about getting your snapback. It's not just about that, because we know that with higher levels of obesity, then there's more risk, right, for other health conditions, especially cardiovascular disease. So when we're talking about, breastfeeding, how it correlates to maternal health, and how it also affects the maternal health or maternal death rate, we really need to make sure that they're getting this information ahead of time. Because if we're in that space where they're delivering, the decision's already been made, right? So we need to all get on the same page. The village needs to know that there are benefits to breastfeeding for maternal health. The providers need to know. I don't think that they do. I really don't think that OBGYN is really talking and having that conversation with his mom about the benefits for you. Not the benefits for the baby, but the benefits for you. Peer support. So we need to be having that conversation amongst ourselves, right? You're not just breastfeeding for your baby, you're breastfeeding for you. So those are just the things that came to my mind in this with this question, and I just want to open it to anyone else to have comments about it.
Well, we all know that we can show clients the benefits of breastfeeding. We actually have a chart that actually compares breast milk with formula. And in breast milk, it had way more properties, more enzymes, more protein, more antibiotics, more probiotics, and not to just mention all the benefits that it has so far as, the constituents, but also the benefits of having less ear infections in the infant, or that's respiratory problems like asthma and things like that. So breast milk is very beneficial. It's natural, and besides that, it's good for your baby.
Right.
It's actually good for all your kids. So, as you guys know, I'm a breastfeeding mom. I breastfed all 4 of my kids. Now, I have a 2-year-old that I still breastfeed as well. I tandemly breastfeed as well. I have an 11-year-old who breastfed for almost a year, 11 months, but he went to straight food from there. My 9-year-old, she breastfed exclusively for 8 months, but then she kind of transitioned over to the food. But she was probably the only one that got sick a couple of times. But my kids do not get sick at all. When the winter season comes, if I think they're going to get I'm kind of proactive. I give them fruits and vegetables and smoothies to kind of, be on the defense side. But my kids don't have the health issues that most kids have. My kids have never missed a day of school. They're all on honor. They're very intelligent. They're very responsive. My 2-year-old, her fine motor skills came in faster because as soon as she got out of the hospital, she got out of the swaddle. She was able to manipulate the breast and hold the breast faster than a bottle-fed baby was able to hold the bottle. And all these different things came into to the positive for me as a mother, and seeing my children, go up the charts faster than the average kid. So breastfeeding has a lot of great factors. I use my breast milk. My kids still drink breast milk when they get a little sniffle or cold because it's way softer. But get a scab, take that breast milk, put it on there. It's better than any coconut oil and all the natural stuff we use anyway. Pink eye, put some breast milk in it. It clears it up. Ear infection, put some breast milk in it. These are the different things that your grandmother taught you and tell you about, as well as when you work with Black community researchers who can share those same cultural beliefs as you as well. And you find out a lot of things that our grandmothers told us is already implemented in the healthcare field.
Yeah, I can agree more of all the wonderful things for children. And I think that we do a really good job, emphasizing that. We really do. But one of the things that I think, even in Black Infant Health Program, I think we can do a better job at is understand that breastfeeding is actually a part of mom's recovery. Like, it's actually a part of her recovery postpartum and her health, and just in our messaging, and the way that we talk to moms about it, not negating that it is beneficial for baby, because obviously we want to do the best for our children, but let's do the best for ourselves too, right? And with that, we need to give them, I know Erica's going to say something, but go ahead, Karen.
Oh, go ahead. We have a couple of questions here, and we've got about 10 minutes.
Okay. So just really quick is that we don't want to just encourage women to breastfeed and to provide them with this information. We want to also give them the support they need to be successful, right? So I just want to emphasize that too, is that, we can give them messaging about their health and their baby's health, but if we don't give them what they need to be able to be successful with breastfeeding, then we're setting them up for failure. We literally are. And so that has to do with resources and doing a good job in hospital, initiating breastfeeding, and then supporting them when there are issues with breastfeeding so that they can sustain with things like a breast pump or, well, preferably a lactation consultant to help, right? Or even a peer support. That's all I wanted to say.
That's so good.
Erica?
I want to try to get to a few of these questions. So Khadijah Fox asked a great question. Do you think that women trying to balance work and breastfeeding is part of the problem, considering the type of economy we have here locally? Many women are working in environments that challenge their ability to continue breastfeeding long term. What can these women do to advocate for space and time to pump once they return to work? Great question.
That is a great question, Khadijah. Thank you.
Erica, it's Flo.
Yeah.
Can I jump in really quickly? Because I just wanted to throw some data in there about this. So this is one of the other pieces. I have lots of pieces of data that keep me up at night, in case anybody is wondering why I say that so much. This is one of the other ones that keeps me up at night. It's over 35% of women, and I don't know what the numbers are for Black women, so this is another gap, but over 35% of women return to work 10 days after giving birth. Many women are working in a shorter time frame for that, but when I started doing research into why 10 days, it's because often jobs give you 2 weeks of vacation. So these women are not actually accessing leave. They're just literally taking their annual vacation and then showing back up to work. So I think when we talk about breastfeeding and so many other things, we have to consider, what does recovery even look like when you are back at work within 2 weeks of giving birth?
Yeah. And I couldn't agree with you more, Dr. Flo, with that. Just looking at the data, it is astounding. And one of the things is that a lot of people don't know what their rights are. They don't know the laws that are in place to support them, that there's a federal law and a California law that, states that your employer does have to, give you time to pump, a place to pump other than a bathroom. There are some things within that law that some people don't necessarily fall under those guidelines, but even with that, advocating for yourself is important. So knowing your rights, number one, and whether you're covered by whatever those laws are with regards to leave, because I think Dr. Flo mentioned leave, your paid leave, and then they have FMLA as well. To be able to make sure you have job security. So a lot of parents don't really even know how to navigate those laws and to know that they even apply to them. So that's one of the big things. So just knowledge, right? The other thing is having a plan in place to be able to breastfeed successfully. So if there is a mom that there is no other way for her to stay home longer than 10 days postpartum, then she needs to have access to pump, and also access to the support that she needs to be counseled and how to maintain her milk supply when she's away from her baby, right? If that has to happen. Or even talking about planning prenatally, you know that you might have to return back to work. So, maybe even, I think one of the things that we don't talk about is finances a lot in our community, but even being able to plan for that time where you might have to take off in order for you to recover. So there's a lot of different factors. When it comes to a woman being successful, absolutely, with breastfeeding when they're returning back to work or school. And I think the biggest one is this knowledge and knowing how to navigate. How can I make this fit into my lifestyle if I do have to go back to work? Or if I am a single mother and I have 5 children and there's no way that I can miss work, right? How can I make breastfeeding happen? as well. So I was a teen mom, and I worked 2 part-time jobs and went to school full-time when I had my first son. And I didn't have to give him any formula. I did, however, have to go back really early to school right after because school is another thing we don't talk about. We talk about lactation accommodation at work, but we don't talk about lactation accommodation when it comes to education. And so having to go back that early, you have to come up with a plan in order for it to work for you. And so I can't, emphasize that enough. Carisha, you might be able to speak to this a little bit, huh?
Yeah, well, I've done all of the above. I was in college when I had my oldest, so I had my baby, and I went back to school a week later. But I went back into the hospital because the side of my face swelled up, so then I had to go back a week after that. But I had all B's in my class as well. With my daughter, my 9-year-old, I had her January 5th and turned around and went to work February 14th. So as a Black mother who's working and, we need 2 incomes, Dad's income wasn't enough. So, we had to work together and make things happen. I've experienced so many different levels, we're working poverty. I'm not ashamed to say it because it's the realization of things. A lot of people thinking they're doing things. It doesn't matter what the tag on your car says. Can you afford to buy a home? We're not homeowners. We're renters. So I don't care about having a Benz. We can't afford a Benz if we can't afford a garage to park it in. So those are the different factors that we were faced against in order for us to maintain stability and the foundation for our home. So I've been in an experience where breastfeeding has been implemented. This is in 2018 when I had my 2-year-old child. They didn't allow me space to breastfeed at first, and then when I was allowed space, it was like they made me feel some type of way, and I'm taking up too much time pumping my milk in the workplace. To the point where I had to actually call Tamisha in. They didn't know what her title was, what she did, and they lied to her. But, we're talking to the breastfeeding coalition, and they didn't even know. So that's what it all goes back to, having a team and knowing your resources and who to reach out to. But it is very hard in the workplace when you don't know the laws, you don't know your rights, and you got to exercise it as much as possible. And you have to reach out to the proper people that can help you exercise those rights. Yes, help is necessary. So it all boils back down to building a team as well. Because I've seen it from so many different factors, from the workplace, from schooling, where I had to rush home because my milk was letting down, and just to get back. And I had a teacher who would always get upset with me for being 5-10 minutes late. And even though I explained to her, look, I'm running home to breastfeed. So, everyone's not sympathetic to your situation, and you don't get to see a lot of us in the situations to be sympathetic. So, building a team is necessary in whatever you do moving forward, especially when it comes to Black health.
Well, I want to respect you all's time. I did 2 things quickly. Somebody asked about the name of Bimla's talk, her TED Talk.
Oh, yes. Actually, you can just Google Dr. Bimla Schwartz TED Talk, and it will come up. And her name is spelled Bimla, and the last name is Schwartz, SCHWARZ. So Bimla Schwartz TED Talk. I'm going to try to look it up really quick and see if maybe we can put it in the chat.
And then somebody asked about, I'm sending it to her. Somebody asked a great question. I think she left, but then I think she came back. She said, where is it? 1 second.
Oh, I found it really quick while you're looking for that question. It's called How Mothers Can Nurse Themselves Healthy. So how mothers can nurse themselves healthy.
Okay, thank you. And there's a great question here about becoming a doula. So she said, this is from Khadija, I'm strongly interested in becoming a doula, especially in this time and with the possible future of our country is about to go, for village support in our community. What would be the best way for me to go about this? This is just the beginning of how I want to support our women and to be a solution to the maternal issues that we deal with. And of course, I'm just unsure of how to begin. Great question.
Right. So one of the first things is just become knowledgeable about the programs that are in your area. There are a lot of different volunteer doula programs, not in San Joaquin County, unfortunately, but there is one that I'm really familiar with in Sacramento County. I know that there's some out of the Bay. And the volunteer doula programs usually will give you opportunities for free workshops for training, as long as you are volunteering within their partnering hospital. And then that way you can get birth experience that way. And as far as certification, becoming a certified doula, one of the resources is Donna, D-O-N-A, and that's one of their certifying organizations. You can look on their website and find out a little bit more. And then there is an individual that I was telling Erica about, Sabia Wade. I've just learned a little bit more about Sabia, and she's a doula that's doing work in San Diego, and she actually has an organization called, I'm looking for it right now. I'll have to find it, but and I'll share that as well. But if you just look her up, you just Google her, you can actually find some doula training that she does, virtual doula training, which is really cool. And so just a couple of resources. So her name is Sabia Wade. It's S-A-B-I-A, last name Wade, W-A-D-E. And then another resource for doula support and information is an organization called Evidence-Based Birth. I really like their website because it's easily navigated. They do virtual doula training as well. And they even have a series for childbirth education for birthing in the time of COVID, which I really encourage a lot of my participants and people that I work with to watch, because it talks about like birthing rights and your legal rights and your human rights as well during this time where we're dealing with the pandemic. So those are like a few resources. And then you're also welcome to email me and I can connect you. So if you want to email me, that's tvalverde, like my last name, 84@gmail.com.
Thank you so much, Tamisha. And I want to make sure Ms. Sheila James had some great feedback. She said, we need to do a Black breastfeeding community town hall with the audience of family members, community members, and providers, and many more women. I think that was that statement. And I think that's amazing. And she talked about many women not being eligible for benefits from their employers considering lactation accommodation, and that many employers don't have lactation accommodations. We were talking about that. So that is absolutely true. But yeah, I concur, Ms. Sheila. I think we definitely need to have a town hall. And I had one more question that I thought was really great, and I don't want to, but I want to pose it more as, and for a few of those folks that do, for those who have to go, thank you so much for your participation, for those attendees who want to go. I do want to ask this one last question, if you are okay to stay on a few extra minutes, just because I think it's really important, just as we're talking about centering Black women during this week of Black Maternal Health Week. So if you're available, just for this last question, I want us to, considering the health equity framework, which stresses having a personal agency and fair access to opportunities and resources that achieve optimal physical, emotional, and social well-being, and also take up Black Mamas Matter Alliance's charge to center the voice of Black mamas, how can we collectively hold systems accountable here in Stockton? Before you answer, I just want to make sure we, again, just realize we're over time, but I want us even to be thinking about this as well after this broadcast. So really, how can we hold systems accountable? Anyone want to comment quickly?
You know, there are things that we can do to hold people accountable for the treatment that they're providing. If you feel that you're having a problem, just know that there are forms that you can fill out, but I would say first get a second opinion. Try to talk to other supervisors of the ones that are not treating you right. You know, you have to you have to do everything in your power and might to try to solve the problem on your own, you know, and then you also can do a barriers to care form if something is not right. You know, you can, you know, do that. You can write letters, you can speak up, you have to be your own advocate, you can go to people in your community and ask them for help and guidance and things like that, but never always just take a first opinion, okay? Get another opinion, because one provider may not see things in the same eye as another provider. Maybe your personality does not mix. Maybe you guys this class just because. Maybe sometimes they're making assumptions about you, or just assume that you're going to act this way, or assume that just assume things about you. So maybe it's not a good fit. So I would say try to get another fit. There is someone out there that can help you. But just know that there are other avenues, and you just have to take the necessary steps and measures and do everything within your own power first, you know, before just blowing off the handle and getting mad and upset with somebody. You know, you want to do everything that you do, you want to do it professionally. Everything that you do, you know, this is a Black community, so I'm going to say you're going to pray about it first, and then take it another step.
I just want to say, just on this, I think giving, and sorry, I'm taking a deep breath because this is a lot, because it's my community, right? Like, holding people accountable is important. We can educate all we want to, but then there has to be an accountability piece. And I think that we should do our best to give a face to and a voice to those that are affected. I think that's what Black Mamas Alliance is doing, as well as telling stories. And I'm grateful that, like, Carisha's on this call, because she can, given this platform, to be able to share her experiences. Because when you put a face to a statistic, it's a little bit more impactful, right? I think the other thing too is transparency. There needs to be transparency in order for there to be accountability. So making sure that those that need bias training and trauma training, that we as providers, I call them out on it. We call them out on it. It's something, has your agency had this? And then, okay, so why are you still practicing in this way? I think if we call them out on a professional level, it's impactful as well as those that are impacted, being able to give a voice to, and in a way calling those accountability just by giving them that platform. So that's my take on it.
Well, thank you.
I agree with you, Tamisha, wholeheartedly on that, and we do have to make people accountable for the actions and the things that they do, because if they don't, we're not going to see a change, and this is just going to be a continued, repeated recycle as it has been. But it is time now for us to step up to the platform and to make viable changes in our community. And I believe I had to help Carisha before, and that's what I had to do, is we had to actually, take the necessary steps to hold somebody accountable.
Mm-hmm. Well, thank you, ladies, so much. I really appreciate your time. And thank you to all the panelists, to all the attendees, to everyone who was able to participate. I will go on record and say that we did have some technical difficulties with GoTo on their side. So that was what we discovered on the back end, that they were having some issues as well as Zoom and other platforms are having during these COVID times. So we thank you so much for staying with us and helping us work through the issues. And we just thank you so much for your time today, everyone, for your questions, all the attendees. And we will have a short survey, exit survey that will be available sometime, hopefully today. So if you have a chance to go ahead and just answer a few questions for us, we would be greatly appreciative. And thank you so much. I'm all for a town meeting one of these days, so be on the lookout for something like that coming very soon. And thank you all. To anyone else.
Thank you.
I thank you, Dr. Hunter.
Thank you.
Okay, and Dr. Flo.
Thank you.
Thank you.
Bye, everybody.
Bye.
Of course. Thanks, Erica.
Thank you so much, sister.
Thanks, Erica.
Thank you. Thank you, Carisha.
Well done, ladies.
Yay. We made it.
As James said, well, there's still 28 participants. Oh, Misha, I was going to say I like what you brought out about the grandma coming to sit in on the breastfeeding course. I think that's good. I think you guys can actually do an event around that where you guys can bring the different generations out of the family, do a family event, and talk about the same thing and more. You know what I'm saying? Because then you can see a transition from the different generations. If the grandmother is in the home and the great grandmother is in the home, you can see a transition from the services they were given, or if we're given any services, to how times have changed in between the grandmother and the great grandmother and the grandmother, and then the daughter and the granddaughter.
Yeah. No, I agree with that. I think that most of the work that we do really should have a generational focus just in general. Like, I really think that that's needed in our community, because there's healing that comes from that. You know, that it's a place where we can address trauma and generational healing too, you know? So I definitely agree.
I agree too. I think it's a good idea.
And I love those questions, and I think we it's a really, really great discussion. It's a really great discussion. So well, thank you, ladies, so much. And you all have a great rest of your day. And we're going to keep doing our part to lift Black mamas up and to give them all the health and birth outcomes that they deserve. So we're worthy, and we can do this.
We can.
Yes, we can.
Yes, we can. That's right. Bye-bye.
Erica, you're awesome.
Now, how do I get out of here?
Thank you.
Yeah,
right.
I'm trying to eat.
I know, right? I gotta.
Who was that? Oh, Krisha.
Yeah,
do we still have attendees, or did they all exit?
We have 21 people. Hey, y'all. They're just listening.
They wanted to stay for the after party.
Right, the after party. This is the after party now. Now we're keeping it real. So funny.
Right.
Okay.
Erica, I did have a question for you though. Did we still have some questions that came up that we didn't get to cover?
You know, there were a couple of comments, so I just sort of, because of time, I didn't address the comments. But no, we kind of Miss Sheila said, does anyone remember the Birthing Project USA? It would go back to that model and have adopted sisters be matched with expectant moms and new moms. I was a volunteer for a few years. It was a wonderful source of support for the women. The sister who started the project is now in New Mexico. Locally, you may know Rolanda Ala Watkins in Sacramento. I'm sure she is still doing it. So
I remember something like that. And, you know, I think that would be amazing because there's that mentorship. And that inadvertently kind of happens in support groups anyway, when you have like, whether it be multi-generational or if you have like pregnant or experienced moms, like moms that, like in my group, there's breastfeeding and pregnant moms. So that ends up happening anyway, like a mentorship almost.
Right.
And I think that would be amazing. That would, and I honestly, or even doula support, like we talked about before. I think we need to bring a doula program to San Joaquin County. I think we need to get funding and make that happen, so that there's more, you know, accessibility for women of color to be able to, especially Black women in this community, right, to be able to go through that kind of training, you know. And that's why I brought up, is it Sabia? I brought her up because that's what she's doing in San Diego. That's exactly what she's doing in San Diego. She's making like that training more accessible to the community, and they even have funding where they actually, if they're African American, they automatically get scholarships. Right.
That's
Exactly.
That's perfect.
So,
Person made a comment too. I think we really need to teach this was Sandra Hunter. I was going to say it before, but then we kind of pivoted to a different topic. So I was trying to find the right time. But she said, I think we really need to teach our young women about their bodies, normal odors versus abnormal odors. Many women do not even know why they only have a monthly period and what is happening in the body. Many women do not know the process of pregnancy, so we really need to teach our women about their body and the beauty of a woman's body.
You know who does a really good job with that right now is Colleen Ray. She actually wrote a book. So she's an author now. She just released her book. I got to look and see what the name of it is. But Colleen, she's from Bags of Hope is her organization. And she does a really great job talking about period talk. Just kind of young women understanding their bodies. And the Dr. Hunter, you still on? Is she still on? No, she hung up, huh? But yeah, so because we both know her. Well, you know her too, Erica. So,
I do.
But she's amazing, and so I think that she does a really good job, you know, talking about that and just maybe doing some more collaboration with Bags of Hope like we've done in the past.
Absolutely.
Around that.
Absolutely.
I'd like to see it done more so in the community and taken away from the schooling, because I don't like how they're teaching it in the schools, because they're teaching different. They're touching a lot more on homosexuality, which culturally and religiously we don't accept. So in my home, I can teach my daughter that, and I find ways to teach her according to her age level and what I think is appropriate for her to know at this age. But at the same time, the school is constantly like forcing. If you don't find a letter saying you don't want them taught that, they're going to force it on them. Yeah. And the work, the paperwork is more explicit. Like it gets year by year, it gets more graphic.
Absolutely.
So I would love to see someone do that, especially in the Black community. Because when I was sitting in the PTO meeting at my child's school, some of the Hispanic women were like, you know, we want the school to teach our kids these things or whatever. And I was taken back that they would want to put so much of that in the hands of the government, facilitating that. Whereas I would like it to be more privatized and also have someone who can relate more to my cultural ways and my religious ways and beliefs.
Right. Well, and I didn't even know this, but she's going to be having, Colleen is actually going to be having a virtual workshop on April 24th. So it's a virtual workshop from 6 to 7 p.m. Krisha, you might want to write this down for Kiana. It's Let's Talk Period. I know she's not quite there yet, but at least you can have some kind of conversation with her. Her book is called Let's Talk Period, and it's actually like a journal. It's a 12-month period journal.
And really I think it's available on Amazon, right?
What's the title of it?
What's her name again? Doctor. Say it again, Miss Sandy.
What's the title? of the book?
It's titled Let's Talk, Period.
Okay.
Yeah, and it's Colleen, spelled Coleen, last name Ray, Colleen Ray. Yeah, so she's the executive director of Bags of Hope, which actually provides like sanitary products for homeless women. It's a really cool organization.
That's good.
Yeah, I'll tag you in it, Miss Sandy, so
Okay,
you can
thank
see. You're welcome.
All right, ladies. Well, I'm gonna have to go.
Yes, I gotta get to work now.
Adios,
This
bye.
has been so nice.
Bye. Love you much. Great job, ladies. Okay.
Hate it.
Bye.
Bye.
I told you I don't know how to get out of this thing.
You just got to end the meeting. You got to end the meeting, Erica.